All right. Good evening, everyone. I'm Dr. Chadda. I welcome you all for this nice webinar. We are going to have some exciting cases. We have in total 4 cases with one international faculty, Dr. Sandeep Kalra. And the other cases are going to be from Dr. Karthik Vasudevan from Columbia Asia Hospital, Bangalore, Dr. Praveen Chandra from Medanta, Ravindra Rao from the Rajasthan Hospital, Jaipur. And the last speaker is going to be Gopala Murugan from MGM Hospital, Chennai. It's my pleasant duty to introduce one of our international faculty who happens to be the first speaker, Dr. Sandeep Kalra, who is from University of Cambridge and Imperial College School of Medicine, London. He's been a very experienced interventional cardiologist and has got 5 years of experience with shockwave therapy. So without much ado, I call upon Sandeep Kalra to share the screen and start his presentation. And we have kept 20 minutes for each of the speakers with 10 minutes of discussion. And in the panel with me are Dr. Mahesh from Cochin, Dr. Shailen Singh from Hyderabad, and we still await the other panelists to join. So as and when they keep joining in, we'll take things forward. Sandeep, you may share your screen and start your presentation. In the meantime, Eshan, do you want to share a video of Translumina? That's what you wanted to do?
No, sir, we will share it later, sir. Let's now start.
Wonderful. Sandeep, you're mute. You will have to unmute yourself. We can see your screen. Yes. Perfect.
Okay. Sorry, bear with me.
All right, you'll have to start all over again. The slides on presentation mode, they're not in the presentation mode. Yeah, perfect. The slides are looking perfect. You may start now. Thank you.
Thank you very much, Dr. Chadda, for the introduction there. So just to reintroduce myself, I'm Dr. Sandeep Kalra. I'm a consultant interventional cardiologist and the director of the cath labs at the Royal Free Hospital in London, UK. So these are my disclosures. Now, just to give a little bit of background to who I am and where I work, and then we'll go into the case. So I work in the Royal Free Hospital, which is based in the north of London, next to one of our more famous landmarks, London Zoo. It's a very old hospital, founded in 1828 on the premise of free medical care. It was granted the Royal Charter in 1837, so moved from being called just the Free Hospital for free medical care to the Royal Free Hospital. It was the first hospital in the world to allow women to study medicine, and the first female was admitted in 1877, moved to our North London site in 1974, and more recently, we've been the epicenter of the COVID-19 admissions in the UK. We've had 2 peaks in March 2020 and in February 2021, and at both points, we had over 500 patients admitted into our hospital with COVID-19 and over 100 ventilated with lots of cardiac complications. So, and just to give a bit of the cardiac background to my hospital, we service over 1 million patients. So for the Indian audience, that would seem a low number of patients, but for the UK, that's actually a very large number of patients for one hospital to service. We undertake a modest amount of PCIs per year by Indian standards, so it's 1,600 PCIs a year, of which 450 are primary angioplasties. We have a dedicated separate entrance to our ED for ambulances to autonomously bring STEMIs to us. So we have a separate entrance for our primary angioplasty service. And in terms of what we offer at my center, pretty much most of the full range of complexity of percutaneous coronary interventions. And in the very near future, I'll be starting our dissection reentry CTO program, but pretty much everything else we do offer at my center. So if I was just to start, I was asked to present a case on treating calcified coronary arteries and in the context of the talk today about my use of IVL. And what I would like to just start with is just to try and show what we should really be trying to avoid in treating calcified coronary arteries with PCI. This is a procedure that was undertaken by a colleague. We can see here that there's a heavily calcified proximal to mid-LAD with severe sequential stenosis, and there's a CTO of the RCA which is subtended by retrograde collateral filling from the left coronary artery. So the approach to here, I think, should be different to what was eventually done. But if I just discuss what was done, this was pre-dilated with semi-compliant balloons. A stent managed to deliver through the artery, through the calcified stenoses, and a decision was made to deploy stents. So you can see on the top left panel there's the first stent going. That's a Medtronic Onyx stent. It managed to navigate around the calcified artery. That seems to dilate when it's inflated. A second stent on the top right panel is now being overlapped there. And then you can see on post-dilatation, the proximal stent really is dog bone. There is poor expansion of that stent there. And we can see the final result down here. You've got an underexpanded stent in the proximal LAD. And it's sad to say that this gentleman actually did not survive too much longer than this and had an out-of-hospital cardiac arrest a few days later. And for me, this really sets the tone of what I would like to speak today about treating calcified coronary arteries. So if I just give my coronary calcium background, it extends back to 2010. My PhD was in vascular calcification and defining some of the more molecular mechanisms involved of dysregulated vascular smooth muscle cells in the media of coronary arteries and generating what we call mineralization competent matrix vesicles, which we can see in the electron microscope panel up here. And these contain proteins that allow calcium to form within the coronary arteries. And in this particular example here, the protein fetuin A. Now, in my experience, I've been using rotablation for the last 10 to 15 years, and IVL I've been a user of for the last 5 years. So those are the slightly more advanced techniques that I will touch upon today. But before I go on to that, I would like to discuss what I see as the challenges of PCI and calcified coronary arteries, and I've got a case that will highlight some of these challenges. So there's no doubt we do see more procedural complications with calcified coronary PCI. We know that there's an increased safety risk. There's a greater risk of procedural complications, including major dissection and arterial perforation. The decreased vascular compliance of calcified arteries and the volume of plaque impedes stent delivery. We know that severe calcium is an independent predictor of unsuccessful PCI, the failure to deliver a stent into the coronary lesion. And as I said, that's a consequence of the decreased flexibility, the decreased compliance of the vessel, but also we often find that calcified vessels are tortuous. You have the risk of damaging the stents trying to ream them through calcified arteries without adequate preparation. As we can see in the cartoon here, you can always damage the leading edge. You can damage the polymer, and you can also remove drug as you try and take these stents through the coronary artery. As I demonstrated in the case I just showed 2 minutes ago, there is an appreciable risk of stent underexpansion. Unless you adequately prepare the lesion and use the correct tools to prepare the calcified lesion, you are risking underexpanding a stent, which may actually pose a larger problem than the original native stenosis. And we know that the severity of calcium in the coronary artery is related to the increased risk of stent underexpansion, and that's subsequently associated with higher MACE events. We know that it's not just the amount of calcium, but it's the arc of calcium, the depth of calcium, and also the length of calcium that predict underexpansion of stents. So there's several parameters that we need to focus on when we're looking at how to modify calcium. Long-term outcome is also poorer in PCI in calcified coronary arteries. We know across several meta-analyses that there are increased MACE events in patients with calcified coronary artery PCI compared to non-calcified coronary artery PCI. And that's been seen across several different studies, and the degree of calcification is related to the worsening outcomes. There has to be special consideration to disease subsets, so anatomy subsets such as bifurcation, left main, and CTOs. These have additional complications associated procedurally with trying to undertake PCI when they are calcified. So these are some areas and subsets that we will need to focus on. And I've selected a case today about a bifurcation to show how I treated that and the considerations I took to help me deliver a successful procedure. And then very finally, just on a science level, we need to understand that there is a difference between medial and intimal calcification. We often talk about deep wall calcification on intravascular imaging. And what we're actually talking about is medial calcification, not intimal calcification when we talk about deep wall. And what we are going to discuss today is the utility of this tool, intravascular lithotripsy, the Shockwave balloon, in helping to treat medial calcification, which up until the introduction of Shockwave, there was no therapy or no treatment strategy to help with deep wall calcium and allow adequate stent expansion. So I've highlighted 6 areas of challenge that I see with treating calcified coronary arteries, but we need to be able to overcome these challenges. We are in 2021, and I think we do have most of the tools that we need to have now to deliver successful PCI to these arteries. Lots of people have come up with algorithms on how to treat calcified coronary arteries. I think probably the easiest one to follow is the SKY algorithm for treating calcified coronary arteries. It's a pretty straightforward algorithm here. If you identify calcium on fluoroscopy or your initial pre-dilatation shows inadequate balloon expansion, you should image and then think about using more advanced tools. So you should think about using non-compliant balloons, high pressure balloons, cutting and scoring balloons, or we should be thinking of slightly more advanced therapy with atherectomy tools or IVL shockwave lithoplasty. There are more complex algorithms. I think these are slightly less helpful. There's quite a large decision tree here telling us how we should be treating calcified coronary arteries, and I don't think this really answers the questions of what we should be doing to deliver successful PCI to these vessels. And if you ask me if I gave my opinion, the single most important thing in undertaking PCI to calcified coronary arteries is intracoronary imaging. And I cannot express how important I feel that is to treating calcified arteries. It is the single most important tool or single most important step in the PCI procedure that will determine outcome. And I would really say that it's not just about imaging at the end of the procedure to check that your stent's expanded. You must image first, image before you treat, image during, and image last. You must image all the way through the procedure to deliver a successful PCI outcome. So let's move now on to the actual case study that I'd like to share with you today. And this is a case study just from a few months ago. A 69-year-old gentleman who presented to my office with a limiting history of stable angina for the last 3 months. His only cardiac risk factor is hypertension, no significant comorbidity. And he was started initially on a beta blocker and some aspirin and a statin, but despite beta blocker therapy, was still experiencing limiting angina. This was a very fit and well gentleman who had no restriction to his usual exercise capacity and was now limited in his activities of daily living. I've shown here now just on the panel, there are 2 images here. We've got a PA cranial view and an LEO cranial view here. And what we can see is it's slightly underwhelming angiographically what we see here. We can see that there is evidence of moderate coronary disease in the mid-LAD just after the departure of the first diagonal. We can also see that it's a large first diagonal which has ostial and proximal disease, but again, a little bit underwhelming angiographically, nothing that looks severe. Based on this gentleman's history of his anginal symptoms, I actually listed him directly for cardiac catheterization. I did not undertake a CT coronary angiogram or functional testing before he came to my cath lab. My standard of practice would be to actually consider PCI in the elective situation with some kind of measurement of ischemia. So I proceeded on to pressure wire assessment here. And in the LAD, the pressure wire assessment showed that there was an FFR of 0.76. I carried out an RFR pullback, and the step up was all across that mid-LAD just after the first diagonal. The FFR was negative in the diagonal, FFR of 0.84. We can also appreciate there is a tight ostial stenosis of quite a large first septal branch here. So I'd undertaken this pressure wire study. I'd identified that there was a positive pressure wire study in the LAD, that there was reduced blood flow in this artery that correlated with this patient's symptoms of stable angina. So my next consideration was to think about how am I going to treat this? Because of the diffuse nature of the LAD disease, it wouldn't be something that I would just go in and stent on angiographic appearance. I decided to image first. And the imaging wasn't because I suspected any calcium, because the reality is on the angiogram, on the fluoroscopy, if this does project well enough, it doesn't appear to be a high burden of calcium on the fluoroscopic images here. So the reason for intravascular imaging now was to help me understand what my distal and proximal landing zones were, and to help me understand what the vessel size was as well. So I undertook OCT of the LAD and also of the D1 branch. The reason I undertook OCT of the D1 is because I wanted to understand the nature of the ostial disease to help me decide if I was going to treat the LAD in a provisional strategy or if I was going to think of a bifurcation 2-stent strategy. So what we can see here now is, this is not available to you in the market in India, but this is the Ultra10 1.0 OCT software. I had the first release of this globally and was able to undertake the first global case using this. There's a lot of additional technology built into the Ultra10 1.0 OCT Abbott vascular software. What we can see here is that it's detecting by artificial intelligence calcium, and this is from various algorithms and feedback of live models that we can detect calcium in the coronary arteries, but also it's going to help me understand the size of the vessel by detecting the EEL. So on the first view here, what we're looking at is a pullback. But on the new Ultra10 1.0, the pullback actually displays to you going from proximal to distal, as we can see the marker go down the co-registered vessel. And what we can see on the axial views, we can see orange lines appearing in this clock face, and that's identifying calcium by artificial intelligence recognition. It's giving us an arc of calcium that we can see in the orange numbers, and it's also giving us a depth of calcium as well. So what we can see is that we've essentially, in the mid vessel after the first diagonal branch, we have got concentric calcium, which is deep wall, up to almost 1 millimeter of calcium in this vessel. So if I just move on to a still frame of this, just to help understand exactly the nature of what we're looking at here. So that's the area of deepest calcium, 0.95 millimeters, and it's a 310-degree arc of calcium. What we can see on the longitudinal view here, we've highlighted in orange. On my user preference settings, I've asked for this to identify any arc of calcium that's more than 180 degrees, because that's where I start to think of using more advanced calcium modifying technology. And if I just let this run on the video again, you will see that the same calcium orange detection projects onto the screen here. And what we can see in the tram lines there is where we've detected more than a 180-degree arc of calcium. So it actually extends back to proximal before the first diagonal. The same now in the first diagonal branch, so imaging from the diagonal on a pullback study into the LAD, but we are now looking as we drive down, we're in the proximal LAD driving down into the diagonal. And what we notice here as well as we approach the diagonal vessel, there's concentric calcium here, more than a 180-degree arc of calcium, and it's deep wall as well, getting up to about 0.7 millimeters of deep wall calcium. And again, just on a still axial view here, we see that there's a 217-degree arc of calcium here in the proximal first diagonal and a 0.84 millimeter depth of calcium. We're able to size, and this is something that's absolutely critical for treating calcified coronary arteries, that we appropriately size to the vessel. Often we have a high burden of plaque in these vessels, so what we're not looking at is the lumen size, we are looking actually at the vessel size. In the dotted lines there that you can see on the three axial views here, we are actually detecting by artificial intelligence what the EEL is. So we're looking at the vessel size, not just the lumen size. This is something, again, an additional feature that Ultra10 1.0 offers. We can see now on the left-hand panel is where my proximal marker is. We can see the lumen size is 3.4 millimeters diameter. We haven't got enough EEL detected to measure the EEL vessel size. And distally, again, we can see it's a 2.5 millimeter vessel as per lumen. And the same for the diagonal there. We have actually in the diagonal got more than a 180 arc of EEL detected. So it's told me that the vessel size is 3.0, the lumen size is 2.15. So we've got to make a judgment call. Landing into our thermometer's vessel would be somewhere probably in between those two sizes. So if I summarize the OCT, and this is now critical to helping me decide how I'm going to treat this vessel. It was unexpected that I found calcium here. I was OCTing because of the diffuse nature of the LAD, not because I expected calcium. But we've seen that there was concentric deep wall calcium in the LAD, and it was involving the LAD D1 bifurcation. So there was calcium at the bifurcation, which itself carries important procedural techniques that you need to help treat first, or you need to modify first before you can develop a neocarina if you're using a two-stent technique. Diffuse atheroma in the mid to distal LAD. Based on OCT measurements, there's a 28.2 millimeter stenosis length. The distal EEL was 3.0 millimeters, the proximal 3.5 millimeters. And similarly, able to size the diagonal with concentric deep wall calcification. It was a 11.3 millimeter stenosis length. Distal EEL was 3.0. My plan here then, based on the concentric calcium, was to use shockwave therapy in the LAD and D1. And the decision here for using that was because of the concentric calcification, but also because there was calcium at the bifurcation. That was the only way I'm going to be able to modify this calcium so that I can generate a robust neocarina with 2 layers of stent. I chose to use the DK crush technique, the reason here being because of the mismatch in size between the two vessels, but also the angulation of the bifurcation. So if I just go into a still angiographic diagram, the first thing I actually did was POBA that first septal just because it was hanging on by a thread. There was a significant plaque burden just at the ostium of that first septal in the LAD. So I thought I would just improve flow there, not to too high a pressure to dissect it, but just to improve flow there before I embarked on implanting a stent. I treated the LAD, I pre-dilated, I pre-treated that with a 3.0 millimeter shockwave balloon, 40 pulses in the LAD, and that resulted in good expansion and adequate modification of the calcium. And then a long 3.0 millimeter non-compliant balloon just to check my expansion before I deployed a stent. And similarly, in the first diagonal branch, a 2.5 millimeter shockwave balloon for 30 pulses, achieved good expansion, and then just confirmed my expansion with a 2.5 millimeter non-compliant balloon, 1-to-1 dilatation at high pressure to make sure I had adequate expansion. So just again on the panel there, we can just see that's the shockwave balloon inflated to 4 atmospheres before delivery of therapy, and you can see there's dog boning off the lesion there in the area of the deepest calcium and the concentric calcium. So I went on to treat this in a standard DK crush technique. The first diagonal, I used a 2.5 by 16 millimeter synergy drug-eluting stent. The first kissing inflation with a 3 millimeter non-compliant balloon in the LAD and 2.5 millimeter non-compliant balloon in the first diagonal. I then went on to deploy my second stent, a 3.0 32 millimeter synergy stent in the LAD. Potted this with a 3.5 millimeter non-compliant balloon based on the OCT measurements. The second kissing balloon inflation, again with a 3 millimeter and a 2.5 millimeter non-compliant balloon in both branches. And then the final LAD pot with a 3.5 millimeter non-compliant balloon. What we have here is the final result. So you can see that there's a good angiographic result. Understandably, that there is diffuse atheroma beyond the stent here, but that was seen there before the start of the procedure. A little bit of wire spasm here, so it actually looked a lot better than this towards the end of the procedure. FFR measured in the LAD at the end, 0.86, so that's improved. It's now non-ischemic. And based on Illumian 3 measurement criteria, there was stent expansion of 92% in the LAD and 89% in the D1. And there's absolutely no doubt that without adequately treating the two branches with shockwave first, we would not have achieved this level of stent expansion. So that summarizes my case. I just want to go through some of my final thoughts just to stimulate some discussion about my case. So the first thing is I will just say again, intracoronary imaging before, during, and after, absolutely critical when you're treating calcified coronary arteries. Now you may ask, why would I image every single artery just in case there was calcium in them? What normally guides me to image arteries when I'm concerned about calcium is if I fluoroscopically identify calcium when undertaking a diagnostic angiogram, or as a lot of my patients do, they have a CT coronary angiogram as a planned pre-assessment. And if they have a CT coronary angiogram identifying a moderate to high calcium score, I will always undertake intracoronary imaging before considering stent deployment. The calcium modification tools that we have available to us today are complementary. We have our non-compliant balloons, our scoring balloons, our cutting balloons, our high-pressure balloons. We have rotational atherectomy, we have laser atherectomy, and we also now have IVL shockwave. And these are not mutually exclusive tools, they are complementary to each other. I won't touch upon this now because I know there is a case presentation coming up for a rototripsy case or a rotoshock case where both rotational atherectomy and shockwave are used together. So I won't focus too much on that now because I know that's coming up later in the program. We must differentiate between intimal calcification and medial calcification. Intimal calcification is modified by rotational atherectomy, by our cutting balloons, by our scoring balloons, by our high pressure balloons, our non-compliant balloons. They do not modify medial calcification, or what we now refer to as deep wall calcification. The only therapy that is able to modify medial wall calcification is shockwave. When we have a high plaque burden, a lot of these therapies do become complementary, but it's important to ablate high plaque burden of calcified plaque before we start thinking about putting in stents. And often what we will need to do is there's a high burden of plaque. We use rotational atherectomy to ablate this calcified plaque first, and then you use shockwave to modify the medial calcification so that you can get adequate stent expansion. And really, to me, IVL has offered a paradigm shift in how we can treat calcified coronary arteries. It has offered a much wider range of patients that we can treat now, and has opened the spectrum of what we are able to deliver successfully. I would summarize that there are no shortcuts in PCR of calcified coronary arteries. you have to take your time, you have to image, you have to follow the steps, you have to respect the calcium, and you will get good results with this. We have the tools available to us today to deliver successful procedures in these patients. And even in my own center now, we are having a conversation about this. You know, should treating heavily calcified coronary arteries be a general interventional skill set, or should we be looking at super specialists and treating this subset of patients, this subset of anatomy? We in our practice have all accepted that, for example, on CTOs, that only certain operators undertake CTO PCI. You know, treating calcified coronary arteries has several steps that need to be followed in a meticulous order, and maybe you need to be doing them at a critical volume on an annual basis to be able to deliver these procedures successfully. This is certainly something we are discussing in my own center now, whether we should have only certain operators delivering this type of high end of treatment. Thank you very much for the invitation. Thank you very much for your time. And I think we're open to some discussion time now.
Okay, thank you, Sandeep. That was a very lucid presentation and a very exciting case which you showed. Before I open up the case for further discussion, just one point which I wanted to ask was that your FFR for diagonal was 0.86. You still went ahead and did a bifurcation plasty with 2 stents. Any thoughts on that?
So the reason I did that was because I was going to end up jailing the diagonal by treating with the LAD across there. And there was a high burden of plaque in the LAD, and I was concerned about plaque shift into the diagonal branch. Although it was non-ischemic, I think to deliver a successful PCI to the LAD, I needed to treat the diagonal as well. Certainly after initial predilatation, I didn't show the images here, but there was loss of flow in the diagonal for a moment when there was plaque shift into there. So that was the reason why I did this. I summarized in terms of the presentation that I undertook Shockwave to the diagonal, but essentially I treated, as you would with all bifurcations, with the plan of a provisional strategy, but I was quite sure I was going to end up using a 2-step strategy here based on what happened after predilatation of the LAD.
That was the only thing which came to my mind out of the case, because I thought if we open up the LAD with a shockwave, it's the plaque opposite the origin of the side branch, or the calcium burden opposite the origin of the side branch, which is kind of more troublesome, vis-a-vis the exact burden of plaque, because at the or the MLA of the diagonal branch. So I think apart from that, the case was perfect. Your talk was amazing, and if the other panelists have some points to discuss, they can come up with their points.
Dr. Kalna, wonderful case, very well presented, step-by-step approach. I do agree with Dr. Chadda's argument that at best I would have treated with as a provisional case. Provisional, I wouldn't have, from start gone with the decay crush in mind. I would have probably just done the LAD and then see how the diagonal behaves. And I wish you could have shown us the images post procedure images. They would have been equally wonderful, because it's a pleasure to see the well expanded stent with the calcium. Wonderful case.
Now, in your practice, Sandeep, what is the percentage of calcium which you get to see during intervention? What
so
amongst the complex PCI?
At my hospital, we've got a huge renal unit. So we're a renal transplant center and a massive regional dialysis center. So almost on a weekly basis, I'm undertaking some kind of advanced calcium modification procedure. So in my practice, I do about 300 PCIs a year, and at least 15% of those I'm using either rotational atherectomy or shockwave.
Perfect. Because India, we get to see a lot of calcium. We have, the general profile of CAD in India is slightly different from the Western world. Disease comes about a decade earlier with more triple vessel disease, more calcium, and we have a very high burden of diabetes. And now we also kind of, since the longevity is increasing, we have an aging population which comes up. So we are getting to see a lot of calcium. And I think you made a very pertinent point that imaging is essential. Imaging is very important, because in a calcified segment, you need to kind of stratify the calcium burden, so that you not only you select your tools for treating this calcium, you also kind of stratify the lesion that, okay, at this point, if I'm using IVL, my 2 cycles are going to be here or 3 cycles are going to be here. And of course, we don't have the luxury of using 2 balloons in a given case because the balloons are expensive. And I have always been advocating that, even though it is said that match the balloon to the distal vessel diameter, I always feel that even if you match it to the diameter of the disease segment, you will do the job. And after that, you use a NC balloon of which matches the distal vessel diameter. So in the case which you showed, if I had to do the diagonal branch, I would have taken a 2.5 balloon. And with the 2.5 balloon, I would have done both the vessels because I'm reasonably sure the disease vessel diameter, if you measure on OCT, will not be more than 2.1 or 2.2. So this will kind of, hug the vessel wall, and the impedance will get matched with the balloon and the vessel wall. You will be able to deliver the therapy. And following that, you can use a larger NC balloon and crack the calcium. And we've learned all these tricks, keeping economics in mind. So
I think that's a very fair point because, a lot of these tools are expensive. They are expensive tools. We are fortunate in the UK that we are reimbursed for these tools. So we're in a slightly different position, but these are all reimbursed through our National Health Service. So I can be a little bit extravagant and take out 2 Shockwave balloons, but I do appreciate that. We are talking about expensive kit here. These bits of kit are not cheap. But then we look at the opposite of this, that 10, 15 years ago, if we'd identified a heavily calcified vessel and we would think about referring for surgery, the cost of bypass surgery is far more than a couple of Shockwave balloons.
Bypass surgery is probably less than half the cost in India of the Shockwave balloon.
Really? Oh, wow.
I think my co-panelist will vouch for this.
Okay. So maybe your surgeon should come to the UK because surgery is very expensive there.
Correct. Any other points, Dr. Shalain, Dr. Praveen? Any other points, please? Dr. Karthik.
This is Dr. Karthik here. Excellent demonstration of IVL and imaging. My point was, instead of putting a stent in the side branch, I think you got a very good result with the OCT. If you see that with the Shockwave in the side branch, you could get a very good result. And I don't think there's any dissection in the side branch, right?
I haven't, just in the interest of keeping to a 20-minute presentation, I haven't shown all of the angiographic images. I treated the LAD first with Shockwave and then post-dilated with a non-compliant, pre-dilated with a non-compliant balloon. And there was a large amount of plaque shift into the diagonal branch. And because of that plaque shift, there was loss of flow. There's TIMI2 flow in there, and I had to balloon it to try and restore flow, which then I felt I was committed to treating that. And just because of the calcium, I think with POBA only in a calcified vessel, you don't always get a good result. So I decided to modify the calcium and then put a stent in. But because I could make this decision after pre-dilatation, then I used a DK crush technique, so stenting the side branch first.
Fair enough. I thought because the result was so good, I thought you could have done away with a drug-eluting balloon in the side branch with a final kissing and avoided a stent. I mean, single stent toxicity would have been a better option. But since you had to compromise in the flow, I think you are left with no option. You have to put a stent there. And because of the plaque shift.
Yeah.
Of course. Thank you, Sandeep. I think we go on to Dr. Karthik's case, and I would request you to stay on so that you can take part in our discussions in the forthcoming cases.
Thank you.
Well, everybody knows Dr. Karthik. He's a very dynamic intervention cardiologist from my city and a dear friend. So Karthik has been at the forefront with complex PCI. So he's going to show us one OCT-guided IVL-assisted PCI. Over to you, Karthik. We can see your slides. Yeah. You can go ahead.
Thank you, Dr. Chadda, for the kind introduction. Today, I'm going to present a case of OCT-guided IVL-assisted PCI. This case is a 79-year-old gentleman, a known case of long-standing type 2 diabetes and hypertension. He had undergone CABG in 2002, and he presented with chest pain and sweating elsewhere. Actually, this patient presented in Ratnal, a small city in Madhya Pradesh. He was taken to a local hospital there where ECG showed T-wave inversion in inferior leads and troponin T was elevated. And he was diagnosed to have NSTEMI, and he underwent a coronary angiogram. Coronary angiogram showed a native triple vessel coronary artery disease. LAD had a proximal 100% occlusion, and circumflex had a proximal 90% stenosis. Right coronary artery looked like a culprit lesion and had a proximal 70% and a distal 90% tight lesion. The PLV also had a proximal 90% narrowing. PD was 100% occluded, but however, PD was filled from the contralateral LAD injection. Lima was patent, and SPG to OM was occluded. There he was advised redo CABG. However, the patient refused to undergo a bypass. He was a 79-year-old gentleman and did not want to go through another procedure like bypass. So he wanted to undergo a PCI. So one of the patient's relative, he was here in Bangalore, so he brought him here. So he came to our center for an elective PCI. So this is an image. Actually, this angiogram was done elsewhere, so I don't have a good image. This is a Lima was patent, and there was some disease distal to the anastomosis. And you can also see the PD being filled by the LAD. And this was the circumflex left main, the tight 90% stenosis in the circumflex. And this is the right coronary artery. There was a 70% narrowing in the proximal coronary artery. And there was a tight 90% distal stenosis. And also the ostium of the PLV had a tight stenosis. PD was occluded completely. So the plan was at that sitting, what I did is I just fixed the OM with a 2.75 to 28 synergy. But unfortunately, there was a dissection in the left main, so I had to put one more stent and complete the procedure. And this is not the case I'm going to discuss. So this is a different intervention altogether. So I did that. And since I saw a lot of calcium in the RCA, I decided to stage this. I was planning for a elective imaging, followed by, depending upon what it shows, mostly IVL to the distal and proximal, less or minus proximal IVL, and then stent both the distal RCA and the proximal RCA. So this was a staged procedure. So I planned it and planned for an OCT. So the distal, since there's a live case in a box, I've recorded this case. So I'll just run through this case. Are you able to see my?
Yes, we can see your image.
So electively, we took this patient.
So your live inbox is not seen.
Sorry?
Your live inbox is not seen. Only still image is seen.
Oh, you're not able to see the running image?
No.
Oh, okay. Sorry. Then I'll go back to my. Okay. Let me share the screen again. Okay, are you able to see this?
Yes.
Okay, I have to start from the beginning. In between, I'll run it fast so that I show things, important things, and I don't, yeah. So this was the angiogram, and we wired and okay, we pre-dilated the lesion, distal lesion, because I had to put the IVUS catheter in. So I thought the lesion won't allow the the OCT catheter. So after the pre-dilatation, we did the OCT. That's the OCT run coming here. So this is a pretty much a big vessel. So I had to do two OCT runs, one for the distal vessel and one for the proximal vessel. So I had 2 runs. So this is the first run. Yeah. So if you see the lesion site somewhere here, this is the proximal run. Okay. Oh. Yeah, and yeah, at the lesion site, there's a ectasia here. Post ectasia, there is a calcium. In the ectasia also, there's a lot of calcium. Anyway, we're not trying to deal with the ectatic portion. And before the ectasia, there was a ring of calcium. You can see that. And almost we measured that, it was about 800 microns. And so the proximal part also we plan to treat. Anyway, distal, we had a calcium of about 700, 800 microns, and also a circumferential calcium in the distal part. Then proximal, we didn't expect this much. So proximal also we decided to treat with IVL. So the measurement of the distal was around 3 millimeter, and the proximal was around, at this dilated segment, it was 4, and at the distal part, it was about 3.5. As Dr. Chadha said, we don't have the luxury of using 2 balloons. We had to use a 3.5 in the proximal and 3 in the distal. So what we did is we choose to use a 3, both for the distal, delivering 40 pulses in the distal and another 40 pulses in the proximal. So this is and proximal to the calcium, what we saw, this is the distal. Again, I think distal is measuring the calcium burden there. So here also around 800 microns of calcium was seen. So it was very clear from the OCT. So IVL was the right calcium modification device to be used here. We wanted to save some cost, and we plan to use the same 3 mm balloon in the proximal as well as the distal segment of the artery. So that's the placement of the IVL balloon in the distal segment. You can see on the fluoroscopy image, there's a heavy calcium in both the superior and the inferior aspect of the balloon. So we delivered here about 40 pulses, and then we thought we'll give a little bit more, and then the 5th pulse also, that another 10 pulses we gave here. I'll go a little bit fast. I think this is all IVL. Yeah, we pulled the same IVL balloon 3 in the proximal segment, and we gave another 30 pulses here. Inflated it to 4 atmosphere and gave about 20 pulses. And after that, I slightly pulled the balloon and inflated to 6 atmospheres, because this is a little bit bigger artery. It was a 3.5. So I went a little bit higher on the pressure and delivered another 20 pulses there. And yeah. So after that, we went with the imaging. So this gentleman was 79-year-old person, and creatinine was normal on the borderline 1.2. So we were very mindful of the dye we were injecting. So only I did a post IVL, I did a distal run, and we could see a fragmentation of the calcium and also pulverization of the calcium. There were a lot of calcium cuts. And post that, we went ahead and deployed the stents. We post dilated with I think that went a little bit faster. We post dilated with the 3 mm 3x8 balloon distally, and proximally with the same 3.3x8 balloon. We did a high pressure post dilatation to get a good lumen before we deploy the stents. So this was a distal stent. It was a 3x38 Zines expedition. So that's the distal stent being deployed. Slight dampening, I had to pull the catheter each time. So the proximal, there was some osteal disease too. This is the proximal stent. This is a 3.5x28 Zines expedition. So we deployed 10 atmospheres. Post that, we saw that there was a dissection there. Okay, I'll do one thing. I'll just go to my presentation. It will be a little bit faster. Are you able to see my slides?
No, Karthik, we are still on your.
You'll have to unshare and then share again.
Unshare and share it, I think. Yeah, I'll do that. Okay. So this is the stent deployment. I'll just run through it. Yeah, that was you can see the dissection there in the distal segment. So there was a dissection at the distal tip of the distal stent. So what we did is we quickly took a 2.5x15 Zines expedition and covered it, and it looked good. And then after that, we took a 3x8 balloon and did aggressive post dilatation to 24 atmospheres. They expanded the stent very nicely. The stent did expand very well. And proximally, I took a 3.5x8 and did a post dilatation. Post that, I did a post OCT run. And this is how it looked. The distal RCA was very nicely expanded. You can see the stent expansion, almost 83%. The distal edge and the proximal edge, you can see very well opposed, no dissection, distal dissection or proximal dissection. And we were very happy with the result in the distal RCA. The proximal RCA also, the distal part of the proximal stent, that is very close to the ectasia, what you see, was not post. So I did a post dilatation with a 3.5x8. Obviously, some amount of studs had gone into the ectasia, which measured about 4 millimeter. So I knew obviously it was underexpanded there and it was not opposing. So the proximally there was no issue, but you can also see some amount of under deployment in the proximal part of the mid part of the stent. So this is the fly through view of the proximal RCA stent. So very well opposed here, and you can see as you come to the distal end of the stent, you can see those red marks there. It's not opposed there, and it enters the ectasia of the vessel. And the distal part, there was no issues at all. It was a very well expanded stent. completely opposed. You can see the entire white line, and MSA is great, 5.12, expansion 83%. Now accordingly, anything more than 80% expansion is good. I think the new guidelines have increased it to 90%, but here we got 83% expansion. So pretty good. So what I did is I took the distal part of the stent which had not expanded. I took a 4x8 NC, and I did a post-dilatation there, and almost pulled the balloon a little bit up and did at low pressure throughout the vessel, and at the ostium again at high pressure with the 4.8 NC. So that was the final result of my procedure. So the result was looking good, and thank you for your kind attention.
Thank you, Karthik. That was an amazing case, complex case. Only two things which I wanted clarification was, number one, you didn't attempt to open the PDA.
I thought about it. I mean, because it was collateralized from the left side.
Okay, fair enough.
I didn't do it because it was collateralized. I didn't want to complicate. Then it will become a complex bifurcation at the distal end.
All right. And second thing, which I would have, done slightly different from you, was I would have certainly stented from PLV backwards, because there was disease in the ostium of the PLV. You were trying to keep it proximal to it. So probably when you implanted the stent, that would have dissected the disease part. So I mean, you had to extend the stent into PLV after that.
Yeah, maybe hindsight, I think you're right. I think I tried to, because 38 millimeter stent I had taken, and I don't know, if distally the vessel size, there was a mismatch. That's the reason I didn't go too distally, because I had taken a 3x38. So there's a 338 would have been a little bit bigger to the distal part of the PLV.
Absolutely. I agree with you there, but then we have now beautifully expandable stents, and which you can put a 2.5 and blow it up to 3 and 3.25. So that is quite possible with majority of the stent platforms. So that is possible. But I think the final result was amazing, a very nicely done case. And the malapposition which you showed on OCT can easily be ignored, because it's less than probably a millimeter or so. So any malapposition less than about 2 millimeters can be left alone and should not be a bother. So I open up this case for further discussion. So all the co-panelists can come in and discuss the case. Dr. Praveen Chandra, I can see you here now. Good to have you here. So maybe if you have some comments, Dr. Sandeep, Dr. Mahesh, Dr. Salin.
I just couldn't see the whole case, unfortunately. But I'm sure, as you were explaining, it was a wonderful case, very well executed. And certainly malapposition is something, which we can best see by OCT only. And if it is not significant, we can leave it alone also. So this is the only information I have about this case. I'm sure there's much more which can be discussed.
Okay.
I have 2 points. One is for Dr. Karthik, and one is for the experts, including Dr. Chadda. Dr. Karthik, where did you leave the ostium of the RCA alone when it was damping and creating problems for you? But just use a slightly longer stent, probably covered the ostium and had a more.
Covered. Ostium is covered.
Covered? Oh, very good.
Yeah, completely covered. Ostium, up to the ostium, it's covered.
Excellent.
In fact, I post-dilated the ostium with a 4x8. So always at the end of the procedure, you never leave the ostium, after so much of catheter manipulation, you better blow it up. So the ostium is very well covered. I blew it up with a 4x8 at the end of the procedure, and I did cover.
Fabulous. I missed that point. To the others, now you have, even Dr. Kalra said that if you have medial calcification, your equipment of choice is IVL. So which are the cases in which you would directly go with an IVL without even attempting once with an NC? Would you attempt with an NC first, give it a try? Maybe the media will listen to you, or maybe it doesn't. Would you directly study? What would you say? When would you go directly? This has to be through IVL only. This I can give it a try with the NC. If it doesn't work, I'll go for IVL.
But Mahesh, this is going to be dictated by the economics. Absolutely. If you want the procedure to be safe, if you want the procedure to be done in a proper manner. There is no other tool which will give you the kind of stent expansion which IVL will give, because it acts, as very correctly pointed out by Dr. Sandeep, that it works on the intimal and medial calcium. Deep calcium, absolutely. And restoration of vessel compliance is possible only with IVL. And if you have the resources and the patient can muster some funds, I think it's a safe device. It's an effective device. And the kind of stent expansion you will get with this are unmatched. And at the end of the day, whatever stent you might use from whichever company, if your MSA is not good, be reasonably sure that this patient is going to come back with stent failure. If not within 6 or 9 months, after 1 year, he'll come back with stent failure. So these are my views. So there are others who can have some other points to add on. Most welcome.
Absolutely. Yeah, go ahead.
That was an absolutely fantastic case. And this is something increasingly in the UK we are seeing as well, where you have patients who've had bypass surgery kind of in mid-age, and then they're going to have secondary and tertiary revascularization by PCI at some point. So, when that bypass card gets played too early, this patient is committed to 3 or 4 revascularization procedures in their lifetime. And we are increasingly seeing this in the UK as well, where we end up with horrendously calcified arteries after bypass surgery that we need to treat the native arteries when the vein grafts block. And one thing just to pick up on was that you mentioned this patient had CKD, and this is something, again, calcified arteries and CKD kind of hunt in pairs, don't they? We normally see the two together. It's quite often that these patients have these as comorbidities. And a lot of my colleagues would normally reach for the IVUS catheter so that they minimize contrast load here. But just one point with OCT, have you tried using saline OCT? Because I find that's incredibly, on a right coronary artery, you get very, very good clearance with just saline alone. On the left coronary system, I find that if you put a guide catheter extension exclusively into the LAD or circumflex, you can get very good clearance of saline. But it's just a way that I often try to limit in these patients contrast load, but just using saline when I'm OCTing.
No, I'm not used saline, and this patient had a creatinine of 1.2. It was not abnormal. It was normal, borderline, upper limit of normal.
Oh, sorry, I misheard then. Sorry, I misheard.
Upper limit of normal.
I think Dr. Mahesh would speak on saline OCT. He's got considerable experience. Mahesh, if you can.
Yeah, I have tried. I'm doing it regularly. I've got 2 publications on saline OCT. RCA, almost always, 95% of the times I do only with saline, and I've got excellent results. LAD, very big vessels, the LMCA is a problem. LAD and circumflex, if they are huge vessels, use a selective catheter, and you can go ahead and definitely do it. Saline works wonderfully. We've been trying to cultivate this with the registry, and hopefully by the time the registry results come out, more people will take to saline. But RCA, OCT to be done with saline only, and even be surprised even with the hand injections that you can get fabulous results with that.
This is fantastic. I mean, I know that you have been doing this, but I have also done a large number of now saline injection OCTs. And, really it is absolutely, giving very nice results. And what I do is I use a hand injection only with a 50 ml syringe. And it works very well. Even for the LAD, I have done it. And I am quite happy about it. And especially in low ejection fraction, in low, this renal function patients, where we have to limit the contrast. We have done interventions with 15-20 ml contrast only, using saline OCT and IVUS together, combining it together, and it works out very well.
Praveen, the important point here, which I think Sandeep brought out and which should not get diluted, is that if you have a calcified vessel, saline OCT gives you amazing results. If you have an ISR or a tight lesion, saline OCT gives you amazing results. And what Dr. Mahesh just mentioned, if you have large vessels, proximal segments to be defined, saline OCT is not going to give you optimal images. So even RCA, which he's mentioning, if it's a 4 millimeter RCA, saline OCT is not going to give you good images. There'll be a lot of swirls and other artifacts which you'll pick up. And in case you want angiocore registration, then saline, of course, is not the way forward. You need to have contrast for angiocore registration, because saline will not give you angiocore registration. Wonderful. So we've had a very nice and fruitful discussion. Dr. Praveen, are you ready with your case? You're
Yes.
next in line.
Yes, sure.
I don't need to introduce him. He's the master of interventions in our country, and a lot of people look up to his cases. So we are very excited to see your case, Dr. Praveen.
Okay. So thank you very much. And I want to start now. How do I start? This one? Yes, sorry. Okay. So thank you very much, Dr. Chadha. And it's a great platform to share this case with you, which we did recently. And
We can't hear you, Dr. Praveen. In case you're speaking, we can just see the angiogram play.
so you don't hear any sound?
No.
Increase the volume of the computer from where you play.
Okay.
Dr. Chandra.
So can you hear something?
We just heard someone call you. That's about all.
Dr. Chandra, Ujjwal this side.
Yeah, Ujjwal.
Sir, on the top bar, where after you share your screen, there's a drop-down menu from where you stop the screen sharing. On the right-hand side, there's an option called More. And the third last option on that More is called Share Sound.
Just a minute. Slowly. So what should I do now? Stop sharing.
Stop the screen sharing. Start the screen sharing again. In the dialog box on the bottom left, there's a Share Sound checkbox. So before clicking on your
Okay. Yeah, share sound.
Yeah.
Okay. Got it. Yeah. Okay. And then now I have to share the screen, right?
sir.
Okay. Yeah. So can you see something? No. ये क्या हो गया? Just a minute. Share screen.
The easiest would be just play the video and you can speak over it. We can listen to you live.
Yeah, I want to do that as well. But now the video is not getting shared. I don't know what is it.
सर वीडियो ओपन कर दीजिए सर.
ये इसको बंद करें. No, minimize it.
Dr. Praveen, you need some tutorials on this. You have been only working in the cath lab, which is not right.
That's right. Yeah. I am so sorry.
No, this is all in a lighter way.
No, that's okay. Because I must learn these things.
So, Dr. Chandra, I will share the video from my end.
To all of you, we are going to present.
Is it audible to everybody?
Very
Yes.
complex, very calcified, a long LED lesion, and which we are going to treat today. And along with me is Dr. Abhinav, who is going to tell the history of the patient, and also then we will discuss the angiogram.
Yes. Hi, good evening, everyone. Patient Mr. Khandelwal is a 74-year gentleman presented with a complaint of chest pain and shortness of breath on exertion from last 1 month. His ECG is showing STT changes in anterior leads. He has one episode of unstable angina and STEMI was diagnosed at that time. His angiography was done outside, which showed osteoproximal heavily calcified lesion which is extending up to mid LED with a TME1 to TME2 flow in the LED and a very tight lesion in the proximal part which is 99%.
Next. Yeah.
Circ is having mild plaques in the mid and the distal part, and the RCA is also having some mild plaques, which is to be medically managed. Yes, this RCA is like little bit proximal. There is haziness and there is plaquing in the proximal part, which is to be managed.
Which we can leave alone.
Yes.
So here as you can see, can you show the first LED angiogram? So this LED is the problem artery, and here the main issue is that it is very heavily calcified, large chunks of calcium are here, and it's a long lesion.
Yes.
So we decided that we'll have to first do a rotablation, and then we will do a shockwave in the proximal part, because that's a big chunk of calcium there. So we might have to, then after the rota we will go ahead with that. So can you just show me the fluoro, please? Okay. So now I have taken a rota wire, which is a rota floppy wire, and I'm going to now push the wire slowly, gently into this is a 7 French guiding catheter. Check please. The wire is moving with little difficulty because it is almost like a gritty sensation, I can tell you. Check please. Now we are in a branch. Let's go to another view, ileocranial. So sometimes it is very tough to position this wire, and then in that case we might have to do an exchange. So you can see that from a very long distance we were in a branch. Check please.
Yes.
Yeah. The guiding goes back. Very slowly it is moving though. So hopefully in another minute or so we will be able to position the wire as distal as we want it to be. I think now we are reasonably down into the vessel. So you can see that the water is dripping, drip by drip, and I am going to check the speed. Not too high, make it less, less. 180. So my base speed will be about 160 to 180. This is a 1.5 burr which I have taken. So you can see this burr is moving reasonably smoothly in the guiding catheter.
So any points of discussion at this point where we have positioned the wire and we have taken a 1.5 burr? So Dr. Chadda or Dr. anybody would like to make any comments, or is it okay?
I just wanted to ask you, Dr. Praveen, is this the standard way of wiring? I've seen most of the people use microcatheter and exchange the wires, but I've seen very few people, including you, who directly wire taking the rota.
Okay. So let me tell you, Dr. Chadda, I do it almost every time I do it this way, and it works out quite well for me. I don't have to do any exchanges, and yeah, so it's okay.
Wonderful.
If we are not able to do it, then only we resort to the.
All right. Because I mean, it's a 09 wire, and it needs to be handled very gently with no kinks. So I think.
So I'll just give some rest and see how it is, because we have done the proximal part is burred well, but in the distal part the burr is getting stuck. It is not moving so much.
So that was a very long rotor run, Dr. Praveen.
Is okay.
Yeah, absolutely.
Can do another.
And the burr was getting stuck at that point, where there was a mild bend. So in case
this is a very common thing to happen, that the burr is not able to push in.
So here you see that the burr is not able to go beyond this point, and it was about almost 3 minutes of burring. So we decided to take the burr out.
And especially that's the reason. So we will see how it is. Okay. So the burr is not moving beyond that, and I think I will try once more. 1 minute 37 seconds we have done, and the burr is stuck over that point. So I think we'll have to maybe just exchange it with the wire and then try to see if we can do it with the balloon or the shockwave. It's not moving. So I think this is the last attempt I did.
You didn't think in terms of downsizing the burr, Dr. Praveen?
Yes. I typically this is what I do, that we downsize the burr. But also, I have seen many times that if you do so much of burring, that you create a very small passage where a balloon can also go. And since our plan was to really, do a shockwave in the proximal part also, and in this, because this vessel is very big vessel. Actually, it was looking 2.5, but when we did the IVUS, I'll show you, it's a 3 millimeter vessel. So we said, okay, let us try and do a balloon here. So we took a 2 millimeter balloon, which went quite easily.
I'll give some nitro. So when we go to very high pressures,
I'll just show you.
This is the all-star wire, and we have the talker here. So what I'm doing is I'm going from the side. If I'm able to do that, that will be better. Branch, same. Yes. I think we are cross. Check please. Open. Check please. So we are quite okay deep into the circulation, and now I will take a 2 millimeter balloon first, because I'm still not sure whether I will be able to take the IVUS catheter inside. So I'm taking a OPN NC balloon to dilate this distal part of this LED where we were not able to take the burr, and then see how things move. So this is moving reasonably okay as of now, and now we are able to cross this with the balloon, which was not being able to be crossed by but the artery is now getting completely blocked off. Chalo, check please. Go up 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16, 18, 20, 22, 24, 26, 28, 30. So you can see that the balloon is taking the shape of this calcific area. Deflate. Pulling it a little bit back. Go up 2, 4, 6, 8, 10, 12, 14, 16, 18, 20, 30, 30, 32. Deflate. Okay, go up please. 1, 2, 3, 4, 5.
We inflated this vessel with this 2 millimeter balloon, and then we did the IVUS. I'll just take you through that because it will save some time. Okay. So this is the IVUS which we are doing.
That is trying
the
to
IVUS co-registration.
Okay. So now you are seeing that he is trying to fix the points for the co-registration. Yeah, it's okay. The path is okay. Perfect. Yeah. Now we are in the normal segment, which is about 3 millimeters. Look at that. How much is the size of the vessel? About 3? And on the angiogram, it looks like a 2.25 or something like that. Very heavily calcified, very bad lesions. Okay, good. So now show us what exactly we saw.
The vessel diameter of average is 4.1.
Okay.
And the luminal diameter is 2.8.
2? At which site?
So this is the ostium of the LED, and you can see it is a big vessel starting. And
At the ostium. So we wanted the distal part first. Let's go to the distal part in the middle. Tell us about the calcium. How much calcium is there at each point?
I'm giving nitro.
Yes. So the vessel distally was also like 3. Yeah. Almost 3. 2.75 to 3. Yeah. Okay.
This is the mark where we started.
Okay.
The calcium starting from this.
Yes.
Also 1 quadrant of the calcium.
Yes.
The luminal calcium and the diameter
And also the calcium. Where is?
So basically, this is the IVA score registration which we were doing in this patient, and the vessel is 3 in the distal part, and it is above 4.1, 4.2 at the ostium. So the plan is to now stent it from the distal to the proximal, and I think we will require 2 stents over here.
So what was the size of the vessel proximally? Okay, fine.
But before this,
now
I see here we are doing the shockwave dilatation.
The catheter has gone so nicely inside. And I will just check once more in that calcific zone. So you can see that as soon as I put the catheter inside, the flow gets completely occluded. So we'll go to 4 atmospheres. 1, 2, 3. Therapy start. So you can see that the balloon is giving way a little bit. Okay. Stop. I'm moving this balloon. Deflate. 3, 4. Okay. So this is 68, 67. Okay.
We have done
Go ahead, please.
serial dilatations using this 3 millimeter balloon, and after this,
Now getting stuck over here.
till the stent.
Go up, please. Okay, I think we are right there. It is now opened up better. Okay, fine. Go up. 1, 2, 3, 4. 4. Okay. So it is still last few shocks left, maybe just 10 pulses left. So we will do one more, and that is the end of this pulses. Okay. This is the last set of pulses, and we see that the balloon is now much better expansion. Deflate. So here I am going to do a small check to see how it is. Yeah, it's looking much better. Now we are in the normal segment. Okay. So this is the normal segment. Okay. This is almost like a 3. So this is the post shock wave. Looks better. Much better. Ostium. And what is the size of the ostium? Because we have to start it from the ostium, the stent. So the vessel size is 4.3, 4.5. So we can, so any stent has to go up to 4.25 if we use a 3 millimeter stent for the distal. And what is the length of the lesion? Show me the length of the lesion from here till that point, till that starting point where the artery was normal. More distally. Okay. 55. So which means it has to be a long stent and maybe 2 stents. That looks much better. So let's use the expedition stent, 3 millimeter into expedition. What is the expansion limit of expedition 3? We'll go up to 4, I think. 3.75. So we cannot take a 3 millimeter stent here.
3.25.
Yeah, so we have to take something which is bigger. So otherwise what we can do is we can go from distal to proximal. So let us take a 3 millimeter 3 into 38 stent. I think we'll have to take a shot.
We'll come up to this point.
Check please. I think we are fine. Go up please. 5, 6, 7. So you can see that the stent is expanded very well. And now I am going to pull it a little bit back and go to higher pressures. Okay, go up please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay, so the same balloon you can see is expanding well, and we see that the stent expansion is reasonable. So this is 12, 14. The same balloon you can see is expanding well, and we see that the stent expansion is reasonable. 2.5 into 33.
We are taking as a 3.5 because it can go up to 4.25. And this is
So here you can see well positioned. No, I think we can't make out on this one. Okay, come back to the RA portal. RA portal seems to be the best. Any back or down, it's okay. Okay, I think it's okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So you can see that the stent expanded very well just at.
So, you must be wondering as to what kind of screen is this. It is because we have this system now, which is the IVA score registration system, which also has a this online stent boost kind of thing, which we have on the fluoro images, but this is through the software which we are using for the IVA score registration.
Atmospheres, and this is a 3.5. Okay. So the stent is expanded well. I'll go with another inflation. Typically we do 2 inflations side by side. Go up please. 2, 4, 6, 8, 10, 12, 14. Okay. So we can see very clearly that the expansion is quite nice and uniform. Deflate please. And now I am going to do a post dilatation using a 4 millimeter balloon in the proximal part of this stent. So first we will start expanding from the ostium and then go a little bit into the middle part of the LED. So you can see that, and go up please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. So the stent is expanding quite nicely. 14, 15, 16. So this is the first part of the stent, the proximal part of the stent being expanded. And you saw this on this enhanced image of the IVA score registration. Deflate please. Stent is being seen very well now. So the stent boost is being done by the IVA score registration machine. How much is it? 8?
Yes.
10? 12? Oh, dilatation with the higher pressures over here at the ostium. So this is a 315 balloon for final inflation into the distal part of the stent. Okay, fine. So the balloon slipped inside very nicely, and you can see that we are now into the distal part. Okay, go up please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Deflate. At this point where the 2 stents are overlapping, we will go to high pressures. Go up. 2, 4, 6, 8, 10, 12, 14, 16, 18, 20. Can somebody give some heparin? Deflate. 2000 heparin. I think to me it looks quite decent. Okay. So you can see that the stent is very well opposed. There is no distal dissection. Here also it looks like very well expanded. Reasonable, a good expansion. Now here it is much less actually. Proximal to mid part there was a narrowing. This point. So go up, keep going up, keep going up, keep going up, yeah. So here might be we'll have to do something. It's about 2.5. Yeah, in the middle. We have to do some with the 3 millimeter balloon. Go up. 2, 4, 6, 8, 10, 12, 14, 16, 18, 20, 22, deflate. So this is this overlap area. Okay, so it looks all right to me that the stent is reasonably well expanded, but I'm going to do some more dilatation with the 3 millimeter because in the mid distal segment there was a point which needs more expansion. 5.5, it's quite nice actually at this point. Yeah, here you take the area. How much is the area? Over here after nitro. Nitro please.
Looks good.
Looks okay. We are fine. So you can see that the vessel is now looking so big, oval expansion, but otherwise reasonably okay. Yes, here we see that there's some degree of a irregularity of the stent, but overall it's quite nice.
So I think this is the final result. As you saw already, we fast forwarded it a little bit because it is getting a little late. So we used 2 stents. We can unshare the screen. Unshare the screen, please.
You're already unshared. You're on the main screen, Dr. Praveen.
Okay, fine. So now the thing is that with this approach, where 2-3 things which I wanted to highlight here. One is that sometimes the burrs can get stuck, but at those points there is some passage which is made, and balloons can cross those lesions if it is a very small spot where the burr is getting stuck, which was the case here. So you saw that the balloon went inside and we kept dilating, and the rest of the work was done by the Shockwave in this. So this was a typical case of combining these 2 technologies together, and then of course choosing a stent with the help of IVUS, we were able to optimize it, and finally everything was okay.
One wonderful case, Dr. Praveen. As usual, you show great cases. So, I mean, this is the first time I've seen, a burr not going and OPNNC entering the lesion, which I must compliment you. Yesterday, I was chairing a live session, and the burr did not cross, and neither did a 1.5 millimeter balloon. But here an OPNNC went through. So compliments. It's hands of Dr. Praveen Chandra which make the difference. So that is one. The other thing which I wanted to know from you was, it's an honest submission. I was not too excited to see the IVUS images because I have been, for most of the calcium, I've been using OCT. So I don't like, and Volcano has, it's a good modality to have with kind of co-registration, but the images don't excite me. So I wanted to know from you was that on Volcano, the calcium did not appear to be, that much as one would expect. So that was one. And two was there any plaque in the left main because you stented the ostium of the LAD? And generally, when we have the ostial LAD disease, we know that 90% of the times the plaque will be extending onto the left main. So did this thought come to you? Did you check the left main, whether there is plaque in the left main or not?
Yeah, that is the reason we were doing the imaging. Actually, we fast forwarded it a little bit in the end and also in the middle. But, there was no, definite plaque there. And the stent was little bit jetting out. I mean, just a fraction, which is what exactly we wanted. So overall, and you saw the first images that there was a half, about 180 degree of calcium lining in the ostium of the left main, and rest of the left main was okay. I mean, the plaque was there certainly, but there was no calcification. So it worked out quite well. And only thing which I was explaining was that the circularity was a little bit oval in the osteoproximal part, but the expansion was quite good. So and even after 4 millimeter dilatation, going up to 15-20 atmospheres, it was.
I think eccentricity in calcified milieu is to be accepted. One should not chase very hard with high pressure balloon dilatation because that's an ideal recipe for complications. Either you'll have some rupture or calcium nodule moving here and there, or you'll fracture the stent struts and kind of damage the polymer and drug. So, I mean, one must accept the eccentricity. Some amount on OCT malapposition is to be accepted because of the uneven surface or the fractures which you create. So I open up the case for further discussion. The co-panelists, okay, I can see Dr. Sandeep wants to make a comment. Sandeep, you can come in.
Thank you. Thank you very much, Dr. Chadda. Dr. Chadda, that's a fantastic case, really, really good case. I mean, an excellent result in the end there. And one comment I just want to ask, because often when we treat calcified arteries, we end up treating very long segments. And there's a balance, and I just want to ask, what do you do in your practice? Because there's a balance between choosing your stent. So you need a stent that's going to be deliverable, but you need something with adequate radial strength to push the calcium out as well. And in your practice, what's your decision making for the stent choice here in long calcified lesions?
Excellent. Dr. Sandeep, I think, these are really, very practical points which you have raised. One is that what kind of stent will you use? Certainly, I would like to use, as you mentioned, a stent which should have more radial strength. So I will not choose a very thin strut stent. For example, I won't choose a Orsiro over here. I won't choose a, other stent, Coroflex, which is a very thin strut in this kind of situation. And that is why I chose to take this Expedition, which is a reasonably, good stent as far as the radial strength is concerned. And also that in very long lesions, in very long calcified lesions, there is a possibility that you will have to put long stents. And there will be situations where you are not able to push stents like Expedition, Zion's Expedition. There we have to resort to putting a thin strut stent like a Orsiro or a Coroflex or something like that. Yeah. But, in these situations, typically, I don't use the BMW wire. I always use the All-Star wire, which is a heavy duty wire, because there are two problems. One is that if you go to very high pressure inflations, then the balloons get stuck on the wire, the BMW wire. And in this All-Star, it doesn't get stuck. And so that is why from the very beginning, we choose this, because if you do too many exchanges and too many high pressure inflations, the wire is completely damaged, and it really gives a tough time at the end when you have done everything. And then, the whole problem is accentuated because of the wire.
Absolutely. Dr. Mahesh, you wanted to say something?
Yeah, there is a 20 megahertz catheter you used, if I'm right, because the angiochoreoregistration is usually done with a 20 megahertz.
Yes.
So I think I also use the same thing, but your images are far superior to mine. Can I borrow your technician?
Of course. I mean, let me tell you, this is the IVUS core registration is a very recent thing in our lab. So I really also do not have too much experience. Since we were doing this case and this, IVUS core registration had already started, I was using it together. But otherwise, I would have used OCT in this case and would have gone ahead. But he was an elderly gentleman. His creatinine was 1.4, 1.5-ish. I thought it is better to not expose him to too much of contrast.
I've been at it for the last 1 month. I'm just not I find a little bit technical difficulties. The images aren't up to the mark. I'm also a predominantly OCT person trying to adjust to the IVUS due to circumstances. So anyway, excellent images, excellent case. At least the length of the stent could be, accurately measured with the OCT IVUS core registration. That I think helped you a little bit. Even the surprise that thing came out that the stent, the diameter was actually 3 millimeters and not 2.5 or 2.25 as we thought it was. Excellent case, Dr. Praveen. Thank you.
Yeah, I think Dr. Karthik wants to make a point. Dr. Karthik, a quick point.
Dr. Praveen, excellent case, fantastic demonstration of use of IVL and IVUS imaging. I wanted to ask you, you did measure the proximal part of the LAD that's near the ostium, almost it was 4.225. And post-dilatation balloon was about 3?
No, 4.
4, okay, fine.
4
Thank
going
you.
to 20 atmospheres. So it was like 4.25 exactly.
Okay, thanks.
Sir, I have a question. You are
Yes,
doing, Dr. Shailendra Singh from Hyderabad. We are doing such long calcified segments nowadays, stent, and fortunately stent expansion is good because of both ROTA and IVL being available. But my question is how how common is restenosis in such cases? Because there appears to be some problem with diffusion of the drug into the calcified segment. The diffusion of the drug from the stent to the calcified segment is not actually very good. And is the restenosis a big problem in such cases?
I do not have any data on this, but certainly we do not, I have not seen accentuated number of restenosis in patients who have calcification. In fact, to the contrary, I have seen that those patients who have calcification, they actually respond very well in the long run compared to those soft lesions where the restenosis is slightly higher.
Okay, both me and Dr. Shailendra happened to be there in the meeting yesterday. We were chairing, and I was shouting from the rooftop, "Don't put long stent, don't put long stents." So I'm not very fond of long stents. And yes, but the important fact is that when you have a calcific milieu diffuse disease, your hands are tied. You just can't leave segments with fractures and dissections. So even though you would like to do spot stenting, but it becomes difficult at times, and one is forced to use long stents. But of course, if you use more metal in a calcific milieu, you are absolutely assured of higher rates of stent failure. But then you have to do what you have to do. So anyone else with any other comments? I can see Dr. Arun, who's just joined in. So Dr. Arun, you want to make a quick comment when then we go on to the next speaker?
Sure. I thought that was an excellent case, Dr. Praveen, where you used everything which we have, ROTA, IVL, OPN, IVAS, and we ultimately got a great result. That's great. I would just, like to answer to your comment. I think that you really don't have too much other than using stents in such lesions. And we do end up using long stents. And what I also find, just as he said, is that the restenosis occurs in areas where the stent is left incompletely deployed. Wherever there are, because of calcification, there is incomplete opening of the stent struts. So, which is now much lower because of IVL and because of OPN. Their regular use has, I think, really helped our practice. But otherwise, in calcified lesions, I also think that we get lesser problems than we expect. Despite the shaggy looking vessel, we end up seeing patients doing reasonably well. So I guess we have to do what we have to do. But great case, Dr. Chandra, congratulations once again.
Thank you. We go on to the next speaker for the evening, which is Dr. Gopal Murugan. So Gopal, if you're there, you can share the screen.
Yes, sir. Good evening, everyone. Respect to the chair and moderators. I shall share my screen.
Gopal comes from southern part of the country. He's better known for structural heart intervention. So he's master of TAVI, percutaneous mitral valve implantation, and mitra clip. So he's going to show us an exciting complex case. Over to you, Gopal.
Thank you, sir. Thanks for the kind words. Not sure I'm going to do justice. It's not extremely complex, I can assure you that.
No.
It's a very
clarified. We are excited. We are excited. Carry on.
So this was recorded yesterday. So I'll just show my recording that gives out the history. Please let me know if you can't hear the volume.
We have a 57-year-old gentleman who has symptoms of shortness of breath and angina. He has a past medical history of diabetes and hypertension, and he was assessed at a local hospital in a peripheral city and had an angiogram there. He was diagnosed of severe calcified disease of the LAD and the left main stem, was offered coronary artery bypass surgery. The patient, however, did not want surgery at any cost and came to our center for percutaneous revascularization. So we've seen him here. His labs suggest a normal blood count, normal kidney function, normal liver function. His echocardiogram suggested wall motion abnormality of the anterior and lateral walls, but there was no scars. His overall LVEF was 45 to 48%. The ECG showed no Q waves. And we've seen his angiogram. His right coronary artery was largely normal. So therefore, we're not going to look into the right coronary artery at all. We have done a check angio today to see, to define the anatomy better in our labs and then treat it in the same sitting. So today we have a right radial artery approach here for this gentleman. We have a 6 French sheath. I've taken EBU 3 because I know the left main is very short, and in case we have to stent the left main, I don't want an EBU 3/5, i.e. a very long secondary curve. So I've taken a 3, which is just about enough if I need support. And using an EBU 3 6 French guide, I've taken some diagnostic images. I will roll through those images. I've intubated the left main. With intubation, I have no pressure damping. I hope you can see the pressure traces. This is after 200 micrograms of nitrate given intracoronary. So it doesn't appear there is a very tight austere left main and the catheter is not damped. So let's roll through the images. Let's get the spider images first. So this is the very first image that we've taken. This is a spider image. You can see here there is clear calcification. You can see on the LAD, not much on the circumflex. Next one. On this image, I couldn't be sure about the left main, but it certainly is a very short left main. You can't be sure if there is a significant narrowing, but it appears there probably isn't. But then the LAD clearly has a long segment of severe calcium right from the beginning all the way to the distal vessel. Next one. And in this view, the cranial view, you can see a very tight narrowing after the large diagonal you can see here, which is also pinched. Next one. Here, the left main looks a bit stenosed in relation to the guide catheter diameter, but we will image this to get better views of the left main. Next one. I think this view shows it very nicely. Can we pause there? Stop. Back. IVUS. And to deal with any calcium, we have laser, we have rotablation, we have shockwave and cutting balloons. So let's see what's the most appropriate, and we'll use whatever is the most appropriate.
I'm just going to speed it up.
We'll go straight with imaging, right from the distal. 1 to distal is 1. What's the size? 1 to 3 millimeter, roughly. Okay, keep coming back. So you can see here the entire vessel is diseased. Come proximally. Pull back. Okay, great. So here the vessel is okay. You can see here it's about a 2.5 millimeter vessel. Keep coming proximally. This is somewhere in the mid LAD. Here it's all soft atheromatous plaque, bit of calcium. This is more significant calcium. Here you can see a big diagonal branch coming out, where just after that we have almost a 360-degree calcium. Come proximal. And here you can see here, stop there. There's a little bit of a reverberation artifact between 11 and 12, but there's clear circumferential calcium, and I think we will be best served with lithotripsy here.
This is at the mid, just between the mid and the distal LAD.
It's just going to go through, and
so I will just drag in the interest of time. So this is the proximal, again, where the angiographic stenosis was tight, i.e. the proximal. There was another circumferential calcium, almost circumferential, you can see here. So more importantly, this is the more proximal vessel. I'm going to concentrate now on the left circumflex bifurcation and the left main to know whether we need to treat and what the strategy is. You can see here, this is the point where the circumflex is coming in. I'm sure you can appreciate the circumflex ostium. It's widely open. The LAD ostium has soft atheromatous plaques, but it's not too bad. It's not too tight to require intervention. We will measure it in due course. So I'm pulling it back with the hope I will get a left main, but there isn't. Straight away, you can see as I'm trying to come out of the ostial LAD, I'm getting the aorta coming in at about 9 o'clock position, suggesting that it is almost a dual ostium. Here you can see here. I'm just straddling between the origin of the circumflex and the possible left main, but there isn't one. It is, you can see here the LAD. As I lose the circumflex, I get the aorta, suggesting it's almost a dual ostium left system with an LAD and circumflex. And we measured it there. And I was convinced that it was not significant. I'll show you the measurements. So we went back and forth, just to make sure we get exactly the perfect plane. And measuring here, we got about just the point where you can just about see the ostial LAD becoming into the aorta. Without the circumflex, we got about 5.9. So it's okay, because the cutoff of 6 is probably not valid here because it's not a left main. We have an independent circumflex essentially. So therefore 5.9, 5.8 is good enough. So I decided not to treat the apparent or possible left main narrowing on angiography. So we decided to use lithotripsy to modify these lesions. So without delay, I will proceed. I will just show you some slides, some recordings that we did on the lithotripsy. This is more for the less experienced people with lithotripsy. Bear with us.
12 lithotripsy catheters being prepared, standard preparation like any balloon. However, one has to be absolutely sure there's no air at all. It's worthwhile de-airing properly because the shock waves travel through liquid media. You don't want air media. So you want a clear liquid medium between the shockwave interface, i.e. from the shockwave electrode all the way to the calcium. You don't want any air. So it's worthwhile spending some time to make sure it's absolutely de-aired, and then we're set to go. So just 1 or 2 words about the shockwave. It's a calcium disruption technology. We are not going to ablate anything here, so there's no risk of distal embolization, number one. One of the other reasons why I chose shockwave, because I was expecting a left main, is it's fantastic for left mains because you can keep wires in both vessels, so one in the circ and one in the LAD, and you can still do shockwave, but you cannot rotablate because you'll have to take a one wire out. So this gives that added security of having all vessels secured with a wire. And often people ask, how much force do you get? What it does is it creates minor explosions. What it does is the explosions crack the calcium. And what is the actual atmospheric pressure generated within the coronary is roughly the tune of 40 to 50 atmospheres. So in a balloon, you can see we normally go to 12, 14, 18, perhaps 20, 24, but you get about 50, roughly about 40 to 50 atmospheres generated inside the coronary. That's the kind of explosion which cracks all this calcium. So when it reaches all the way up to the adventitia, it's important you have good contact, because if you don't have contact, you don't transmit the shockwave. That's why we need the liquid, and we need an appropriately sized balloon so that there's contact all the way through and through up to the calcium from the electrode.
So without, I'm just going to raise here. So here you can see here we treated the distal there. But while we treated the distal, there was still dog boning. This is a 3 by 12 Shockwave balloon. That's the balloon we used for the proximal and the distal circumferential calcium. In the middle, there was not much narrowing, so we didn't treat it. So we mainly concentrated on the proximal and distal, where there was tight circumferential calcium, and the balloon used was a 3/12. So we gave about 4 full cycles to the mid to distal vessel, and then I moved proximally and delivered 4 full cycles to the proximal vessels. Subsequently, we did another IVUS to see where we were.
Yeah. I think this is the area where we.
So this is the IVUS which was done after the shockwave delivery. So no balloons, post-dilatation balloons have been used thus far. The only balloon used was a shockwave. You can see here there is a calcium. I hope you can see my cursor. You can see there is a calcium breakage around 11 o'clock position, creating a step where the calcium is cracked. And I'll show you a bit more treatment here. Here again, you can see this calcium which is broken between 10 and 11 o'clock position. There was a crack here at 10. And then we post-dilated with 3 NC balloon and then deployed stents. So the stents I used was a 2.75 by 38 Multimaster. I sirolimus eluting stent from the distal to the proximal, and I used a second stent, which is a 3/24, overlapping this distal stent up till the proximal, just to the ostium.
Answers with the wire, just get stuck in the wire for some reason.
And naturally, you would expect there was some resistance pushing in and out, but I didn't have to use any guide extension. It was well dilated. I was able to place the stents without any problem. Once the stents were placed, this is just to show you the positioning of the stents. So you can see here, I just left about 1 or 2 millimeters from the left circumflex ostium just to avoid any plaque shift. And the size of the stent is 3/26, i.e. overlapping into the distal stent, which is a 2.75 by 38. Both were Ultimasters. So that's the positioning. You can see here, before I started taking stents, I left a safety wire in the aorta because I knew, pushing these stents in and out and the balloon, the winged balloon coming out, I'm likely going to suck in the guide and create some damage to the atheromatous ostial vessel, or perhaps damage the stent. So I left a safety wire in the aorta, which you can see hanging in the aorta to prevent the guide from being sucked in. So I will move now. So once I deployed the stents, I post-dilated with the NC balloon distally and proximally. But after all that, I felt there was some stent under expansion at the distal vessel. So where you can see my balloon position, I decided to use an OPN. Here I'm using a 2.5 OPN balloon, went up to 40 atmospheres, and the first OPN balloon actually ruptured. So I used a second balloon, and I used both the balloons, and after that I was reasonably happy, yet there was a little bit of under expansion. I wished it could have gone up even higher, but at this point I wanted to get the inputs of the other members of this panel, and perhaps from the moderators and chair, as to what you would have done. But let me finish this sequence. So this is just the final OPN balloons that I used. And after that, this is a final IVUS of the ostium, just to make sure the inflow of the stent is okay, and I've not damaged that ostial LAD or short left main, whatever you may call it, with all the maneuvering. And everything was okay. And this is again going back in and out, just to be absolutely sure with the IVUS that there is no inflow pathology that I have created. And the stent was about 2.9, 2.8 proximally. So with that, we finished the case. This is the final angio. Now, if you can see my screen, I don't know if you can see my pointer. Can you see my pointer?
Yes, yes, your pointer is well seen.
Where you can see here, the distal diagonal was of course, but there was good flow, but I was not happy with the stent expansion. I wish I could have got slightly bigger diameters here. With the IVUS, I got only 2.5 because I want to get a 2.75. We just couldn't get it in spite of using two OPN balloons, both going up to 40 atmospheres. Mind you, OPN will, gave me 40 atmospheres. The shock waves, I used 4 cycles there, which would have given me 50 atmospheres, with so many cycles that I used. But in spite of that, I couldn't get any better. So I just left it there. And the final result was acceptable to me. There was no inflow-outflow pathology on IVUS, the left main or the ostial AD, whatever you may call it. In this case was okay. And with that, I finished.
Thank you, Gopal. That was an exciting case. I'll just set the ball rolling by asking a couple of questions.
Sure.
Is radial your route of choice for calcified coronary artery disease?
Pretty much, because if the radial is pretty good size, I have no problems taking a 7 French also. If I had any intentions of double vessel culotte and all that, I'd happily take a 7 French also. The radial vessel is big enough. Otherwise, I would change quickly to femoral. This chap's radial was big, very big.
I think point well taken, because those who come with calcified disease, and especially females in our setup, small build females, I absolutely don't touch their radials, because in the middle of the procedure they start having pain, spasm, and then almost 50 to 60% of the radial, calcium which you are doing will require some kind of guide extension catheter. You have to pull, push, deliver hardware which is bulky. So that makes the procedure a little complicated.
Sure.
And if you have a shortish left main, the kind which you had in this present case, I would have preferred a jail guide with a guide extension if need be. Because there is always that risk, because it was a big loop with the guide extension, and very smartly you did the case with the wire hanging in the aorta so that the guide does not get sucked in. So, you were totally aware of all the nuances and you took steps, but I think for the benefit of those my junior colleagues who are there, I think it's a good, if you're doing calcium and if you're doing, smallish frame patients, it's always better to use a femoral 7 French so that you have adequate space for upgrading your instruments. The other thing which I noticed that are you very fond of coronary roadmap, because that was constantly on?
Yeah, so it just helps us minimize contrast use, and we have the facility. So we use it, and almost we use IVUS and everything also. So we try and minimize injections,
All right. And I was quite amazed post stenting, the OPN balloon burst 40 atmosphere. That's what. So this is pretty rare that post stenting. Maybe there was some nodule, because we've seen these balloons rupture with, especially in milieu of calcific nodules. If you have a nodular calcium, you have eccentric expansion, and then the nodules kind of cause the balloons to rupture. But post-stenting, it's a rare thing. And I, at least in my practice, I haven't come across. Maybe I'll open up this to the others on the panel to. So I always emphasize that if you got a calcific disease, do whatever you have to before the stent is implanted. You know, there are a lot of operators who just create a passage for the stent and then start working on the calcium behind the stent. I am absolutely not an advocate of that, because you can get into a thick soup with, a calcific milieu behind, and then you have metal struts in front of that. And now trying to work through those metal struts and trying to expand what is there behind the stents is not a very pleasant thing to do. So I open up the case for discussion. Nice case, Gopal, and a lot of learning points.
No, thank you.
I
wanted to ask a question, perhaps for my own learning. Could I have done anything better for that distal stented segment, which didn't go up as much as I would have liked to? Obviously, I've used lithotripsy. I've delivered 4 cycles, which means 10 into 4 or 50 atmospheres to prepare the bed, and then put the stent, and I've used an opium balloon. Perhaps, someone, my colleagues and the clinical specialists here suggest, why don't we put another opium balloon and see? But I didn't think it was going to be useful or cost effective. Had it been about a few thousand rands, I'd have happily stuck one in. But putting another opium balloon there after the stenting, after opium, hoping another 50 atmospheres is suddenly going to make a difference, that previous 50 atmospheres multiple times delivered 40 and 50 didn't do much. What do you think?
I'll tell you what is most important in the calcific milieu is to have a tool which tells you about the calcium thickness.
Yeah.
And then probably IVUS has a little disadvantage because the sound waves gets reflected on from the surface of the calcium, so you really don't get to know about the thickness. So if you get to know through OCT about the thickness of the calcium, you can grade your IVL pulses. If the calcific plate is less than 500 microns in the proximal segments, I won't use IVL at all. I would rather use more cycles in a thick part or in the segments where I see more calcium. And I generally post IVL, I put in an NC balloon and see if there is dog boning, or a balloon which matches the distal vessel diameter. If there is dog boning there, then I would go back with more cycles there. So I mean, this is called focused delivery of the lithotripsy rather than doing it distal to proximal. And this all has to be done before you put in a stent. So I particularly am fond of OCT in calcific vessels because it gives you much more information than what you get from IVUS. IVUS will just show you a ring. It will just show you that there is calcium. It is segmental. It is circumferential. It is so many degrees, but it doesn't we have the scoring system which is available on OCT, which talks about thickness, length, and this extent and distribution, the arc, which is not there with the IVUS. So, I mean, had I picked up at that particular point, post-stenting things are difficult, Gopal. Post-stenting.
No, pre-stenting, so let's say we used OCT and we discovered a very thick sheet of calcium. You would suggest delivering perhaps the full 8 cycles?
So I won't say deliver all full 8 cycles. Deliver 2 or 3 cycles. Correct. Put in an OCT catheter and see if it has made any difference. So if there are cracks there, you put in an NC balloon, put an OPN balloon, and go high pressures. It will just fracture it. It will just pulverize that calcium. Because what lithotripsy balloon is going to do is that it's a balloon for the sake of calling it balloon, but it's a device. It's a device which is delivering shocks. You very nicely explained. So it's just going to crack, but you have to expand that segment. So after the IVL has been used, you need to do high pressure dilatation in those segments.
Yeah. So I used 4 cycles, 4 into 10 in that area, 4 into 10 in the proximal, and I used a 2.75 NC. That's all I did before. Maybe I should have persevered with an OPN before. Maybe
probably. So in hindsight, we can say so, but I think what you did on the table was absolutely perfect. But we do have some cases like this. Okay, Karthik, quick comment, and then we go to Sandeep. Both of them have raised their hands. Okay.
Yeah, Dr. Chadda, what I was thinking is, excellent case, Gopal. For the plaque modification, could you have used plaque modifying balloon like angiosculpt or a cutting balloon like Wolverine, and then you could have got a better result, I think.
Sure. I mean, this is my thought, correct me if I'm wrong, with calcium, with thick calcium like this, which you saw, very circumferential calcium, I've not been terribly impressed with the angiosculpt or the scoring balloons, because they don't seem to cut through thick calcium very well. I just end up with a lot of dog boning. I mean, this is just my thought. I may be wrong. But with thin calcium, with fibrotic, perfect. You know, it cuts through ISRs. That's where traditionally I love them, where there's a lot of ISR, soft tissue, fibrous material or fibrocalcific, but pure, thick calcium. I've never been terribly impressed with them. Maybe I'm wrong, but I'll be open for your comments.
Yeah, and one more thing is, when you use the NC balloon post IVL, the 2.75, and did it yield, or there was a dog boning there?
There was a dog boning there. And at that point, I was not even the IVL balloon, although it's not meant for dilatation. You can see from the shape, you know, it was clearly compressed towards the distal end. And I delivered all 4 runs, which means 4 into 10, just in that spot, with the hope that angiographically at one point I'll see it going up. And that never happened. And after that, I used an NC balloon going up to 28 atmospheres. Beyond that, you know, there's
I think what Dr. Chadda is telling, it's very important. You have to prepare the lesion before you deliver the stent. I think when you see the dog boning and the NC is not expanding, I think you could have used a cutting balloon and try to open it up before delivering the stent. And once you deliver the stent, it's very difficult, whatever you do. In fact, I've had cases where I've delivered the stent and then the IVL also. It doesn't open up. It just doesn't open up, give way. I think you have to do the preparation of the bed before you put in your stent. I think a slightly different thing, what I would have done is I would have used the cutting balloon like Wolverine and gone to about 12-14 atmospheres, tried to open it up before delivering the stent. Otherwise, it was fantastic.
Yeah, absolutely. I think what retrospectively the learning is, maybe I should have just used a cutting balloon before the stent went in. And although after the stent went in, once I realized this has happened, I thought I'll put a laser catheter and then do it with contrast. That's another option. But then, you know, after all this case, you know, wheeling the damn thing in and sticking a laser catheter, I thought I'll just bring him back, because done yesterday. I'm going to bring him back and see how he is, and perhaps do my thought process now is to just bring him back, see how he is, and have a very low threshold to do just an elective laser. Put some contrast there and just laser it with contrast. That's my thought process, but just mention it.
That's a good idea. You can do that, I think. Yeah.
Okay. Sandeep, your comment, please.
Dr. Kowal, another fantastic case, a really, really difficult case, actually, and a good result in the end. The one comment I just want to make is that when we've got such a high burden, this patient had intimal and medial calcification. When you've got such a high burden of intimal plaque, the absolute key is that no matter how hard you dilate it, it's conservation of matter. You're never going to compact that to 0. So that's going to have a minimum size. And we saw that actually very nicely on your last IVUS image, that kind of from 9 o'clock around to 3 o'clock, there was an arc of matter behind the stent that you're never going to get smaller, no matter how big an OPM balloon you take in there, no matter how high a pressure you go to. And what you will actually do, the only risk you have is actually of pushing that outside of the adventitia, the higher pressure you go, and getting a perforation. But there's a critical, it's just conservation of matter. You are never going to get that less than what it was, because you've already dilated it to an adequate amount. And that is just a limitation of the technology that we have at the moment. Because even at the beginning, I don't think rotational atherectomy would have actually helped the situation that much. It would have modified the intima. It wouldn't have actually taken the plaque away. And you're always going to end up with, when you've got hard plaque, when you've got calcified plaque, you're never going to get that to a smaller volume. And it's the same argument that we have with in-stent restenosis, when you have either neointima or you have neoatherosclerosis as the cause of in-stent restenosis. if you end up putting in a second layer of stent, it is like the Russian dolls, that the inner layer is always going to have a smaller MSA than the outer layer because you're trapping plaque between the two layers. And no matter how hard you post dilate, you're never going to get the two layers of stent opposed against each other.
Sure, very valid points. Thanks, Sandeep.
Wonderful. Dr. Mahesh, you have some comments.
The problem, the whole thing is that there is nothing left to speak after Dr. Chadda speaks. So we have an issue there. So I would have done probably the OCT and the basic funda of having to prepare the bed. Because once you have dog boning after the stent has been deployed, it is next to impossible to regroup and salvage the situation. You used a 20 megahertz catheter or a 40 megahertz catheter? I think
45.
the second. Pardon?
45 megahertz.
40 megahertz. Okay. And this angiocorregistration is from the IVUS.
Yeah.
Oh, fabulous. I have the same machine. I've learned a lot of new tips today from Dr. Praveen.
Dr. Mahesh has been busy learning about Volcano IVUS.
Now we are, and at one point, I don't know how laser is going to help you in this calcium. But all the studies so far have shown that laser is, it can destabilize the tissue around the calcium, but will not do actually anything to the calcium.
Absolutely right.
Absolutely. I think we use laser mainly for the explosive effect.
With contrast.
Not really for its effect on ablating calcium directly, because it doesn't work. It more works on the bonds between the calcium, the carbon bonds. That's all it's going to take away. But it's just a desperate measure because now I've got a stent in. There's a nodule clearly that just wouldn't give way. You get bigger explosions, and hopefully you will loosen up the tissue further. It's the hope, because obviously I will not get you outside the stent or make anything.
Wonderful. I think very nicely put across that laser is of course going to act only on the superficial calcific sheet. It won't act on the medial calcium. And in the opening talk, Sandeep brought out very nicely that how this therapy works and how these sonic waves go on and work on the medial and the deep calcium. So this is the only tool which works on the deep calcium. And I mean, in any given case, we need a combination of tools to work on. You need to have multimodality approach to a given calcific case. So what Karthik brought out is a very valid point, using atherectomy tools post either rotational atherectomy or post IVL. If you use these cutting scoring balloons, they really help you, because they at times it's thick fibrous element which is causing under expansion. So they work well, and between the two of them, I think angiosculpt comes to the semi-compliant balloon and the Wolverine comes to the NC balloon. So either of these two can be chosen. They are equally effective. The advantage of angiosculpt is that if you're working on the proximal segments on the left mains, you can probably go up fast and come down fast, which is not possible with Wolverine, where you have to go up a little slow and come down a little slow, because these blades can cut through the balloon fabric. So I use these quite frequently in calcific milieu. And I mean, whatever you have to do it before you put the stent. After you put the stent, you can just hope that it expands to whatever extent you want it to go up. So I have a good news and a bad news to share. The bad news is that Ravindra is stuck in a case, so we'll be deprived of his case. So we'll not be able to have him in the platform. And the good news is that I think we'll all can have a nice weekend, early nice weekend, kind courtesy Ravindra's absence. So if there are any comments from the co-panel, it's been a wonderful evening sharing such wonderful cases and learning so much from each other. So I welcome these comments, and thereafter maybe Ehsan would like to talk something about Translumina. Since we have time, you can go ahead and do that.
Thank you, sir. Are there any moderators' question, Pankuri, if you can, because generally it comes on the...
We generally covered all of them, and we covered all the points which were there.
Dr. Chadda, I got one doubt. I mean, in case if you're done an OCT, and you had seen the calcific nodule, I think OCT undoubtedly gives you better images. Would you have changed your strategy from IVL to rotablation there, get the wire bias and ablate the calcific nodule? That would have given a better result. I think hindsight, I think looking at the stent expansion, I would have done the other way, put a rota catheter there and done the rotablation in IVL, and then the proximal part you could have used the IVL.
See, Karthik, the issue what happens with the calcific nodules is that everything is unpredictable. And whatever you might do, whether you get optimal or suboptimal results, in hindsight, you will always think that had I done this, that would have been better. So that is the central premise on which it works. Now, if a nodule is there in a vessel which is slightly expanded, then it becomes very tricky to create a wire bias. Now, the different ways of creating wire bias are that you use a guide extension catheter, bring it close to the take it inside, so the wire bias will change, or put the rota wire in a different branch.
In a branch, different branch.
Absolutely. So, but then if the vessel is slightly bigger, then you need larger burrs to shave off a little bit of this thing. What works the best and is not available in our country is orbital atherectomy. You know, orbital atherectomy works probably the best for nodules and it shaves them off. But we don't have the orbital atherectomy now. Rota is indispensable because if nothing gets in, rota will get in. We know most of the other tools which you use for calcific disease are, they have larger profile and they need to be pushed in, and the profile of OPN, the cutting balloon and the scoring balloon is kind of similar. And so is IVL. So the important thing is that it's extremely tight lesion. You need to rotablate, you need to create a passage. But if it is a nodule which is sitting there, probably orbital atherectomy is the tool to be made available, and that can shave off. But the disadvantage of orbital atherectomy is that it cannot work in extremely tight lesion. You still have to create a passage for the orbital atherectomy to get in and to do the work. And yes, of course, you have to do it carefully. So
yeah,
it is calcium is kind of tricky, and I always say that one must accept slightly suboptimal results, and if you chase perfection, then you are kind of getting into a territory where you will kind of regret that I had such a good result and now I have damaged the stent or I have caused perforation. So one needs to be careful.
Absolutely agree with you, Dr. Chadda.
Any other points from the panelists? I think it was a wonderful evening, and I thank one and all. Ehsan, you have something to?
No, sir. Thank you very much, sir. I just at the end, I wanted to reiterate the same what you were saying. It was a great evening. Basically, this calcium masterclass, this is a new concept. Series which we had just started with the help and support of Shockwave and TTL at India, Translumina at India. This was an opportunity basically to have quite a detailed look on the aspect of coronary calcification with the help of experts from India and internationally also, and at the same time trying to get the distinguished speakers like all of you. And this has been yesterday has also been a grand success with about more than 800 audience being part of this, and I'm sure the similar would be the number today. We'll just be getting the numbers now. So it was a great academic feast which was there, and thank you very much to all of you, sir, on behalf of Translumina as we sign off for the program. Thank you very much once again.
Thank you, one and all. Thank you, Translumina. It was a wonderful evening. I learned personally a lot of things. So it was a great time spent together. Thank you. Thank you. Bye-bye. Bye.